Good morning, students. Without your involvement, you can't succeed. With your involvement, you can't fail. So, involve in your studies and you succeed in your life. It's said by APJ Abdul Kalam. Today, we are going to discuss about the topic endometriosis. Endo means inside. Metra means womb or uterus. So, the endometrium usually present inside the uterus or womb. Uterus consists of three layers, that is endometrium, myometrium and serosa. Endometrium, further it is divided into two types, that is basal layer and the functional layer. So this is the inner layer or inner lining. It is shed during your period. So this functional layer usually shed down during the menstruation. In myometrium, this is thick middle muscle layer of the corpus or fundus. This expands during the pregnancy to hold the growing baby. And serosa, this is a smooth outer layer. So let us see what happens in endometriosis. Definition: occurrence of ectopic endometrial tissues outside the cavity of uterus, that is known as endometriosis. The presence of functioning endometrium. So usually this functional endometrium is present inside the womb or uterus. But when this endometrium, this functional endometrium is present inside other than the uterine mucosa, so that is known as endometriosis. We can see the other sites where the endometrium usually grow other than the uterus because of some conditions, that is abdominal. Common sites are ovary, pouch of Douglas, uterosacral ligament, broad ligament, rectovaginal septum, rectum, pelvic lymph nodes. The rare sites are gut, appendix, ureter, urinary bladder, cul-de-sac, sigmoid colon, pelvic peritoneum. In extra-abdominal sites are abdominal scar of hysterectomy, caesarean section, tubectomy, myomectomy, umbilicus, episiotomy scar, vagina and the cervix. And the remote sites are pleura, lungs, deep tissue of arms, thighs, kidneys, gallbladder, diaphragm and the stomach. You can see these are the sites from this picture. Usually the endometrium grow because of some conditions other than in the uterus. So we can see the pathogenesis of endometriosis. There are 5 reasons. First is retrograde menstruation, that is Simpson's theory. So we can see what is Simpson's theory says. This is a retrograde flow of menstrual blood through the uterine tubes during the menstruation. When this flow is retrograde, the endometrial fragments get implanted in the peritoneal surface of the pelvic organ. You can see from this picture. This is when usually the menstrual flow through the vagina, but sometimes it will go reversible flow through the uterine tubes and fall into the pelvic peritoneum. So that is, there is a retrograde flow of menstrual blood through the uterine tube during the menstruation. Just now I shown you, and endometrial fragments get implanted in the peritoneal surface of the pelvic organs. That causes cyclic growth. So each menstrual cycle, what will happen? The endometrium which is fold in that cavity, in that area, every month the cyclic growth and shedding of the endometrium at the ectopic sites occur under the influence of endogenous ovarian hormones. So that causes pelvic endometriosis. Next is coulominic metaplasia, that is Meyer and Ivanov's theory. There is chronic irritation of the pelvic peritoneum by the menstrual blood flow causes coulominic metaplasia. So that is coulominic metaplasia. That is endometriosis originates from the metaplasia of the specialized cells that are present in the mesothelial lining of the visceral and abdominal peritoneum. So what is metaplasia? It is a change in the form, that is process whereby one type of mature tissue is replaced by another type of mature tissue, not indigenous to that organ or tissue. That is metaplasia. So that is colony metaplasia occur that results in the endometriosis. Also, the Mullerian tissue remnants may be trapped within the peritoneum and that undergo metaplasia and be transformed into endometrium. So that is colony metaplasia. Next we can see, this is just now I showed you the picture. So next is direct implantation. The endometrial or decidual tissue started to grow in the susceptible individual when implanted in the new site. So when it fall in or implanted in a new area, so according to the susceptible individual, it will grow in that particular site. It occurs in the abdominal scar following the hysterectomy. So when the time of hysterectomy, this endometrial tissue, if it fall in the abdominal scar, it may grow in that site. And cesarean section, tubectomy and myomectomy, and also at the episiotomy scar, vaginal and cervical site. So in these sites, if the endometrial tissue falls and if the woman is susceptible to the growth, it will grow in the direct implantation. The next one is lymphatic theory, that is by the Halbert. It may be possible for the normal endometrium to metastasis. We already told what it is, metastasis, and the pelvic lymph nodes through the draining lymphatic channel of the uterus. So through the lymphatic channels, that is the lymph node channels, the endometrium goes and in the lymph nodes this endometrium started to grow. That is the lymphatic theory. Next is the immunological factor. The peritoneal fluid in the endometriosis shows the presence of macrophages and natural killing cells. So, implanted T cells and natural killing cells activity and altered immunity of the person causes in the woman may increase the susceptibility to proliferation and the growth. So, what we said just now, that is the peritoneal fluid, that is which when we it contains endometriosis, the natural killing cells and macrophages also will be, if that it is present in the, so when the implanted T cells and NK cells activity and altered immunity causes in the woman may increase the susceptibility to proliferation and growth of the endometrium. It causes endometriosis in the distant sites. Next is the other factors, that is genetical factors, multifactorial, vaginal and cervical atresia. So if the vaginal and cervical atresia, what will happen? Menstrual flow will not go outside. So it may go for retrograde menstruation. The menstrual flow go through the tubes. That is retrogrades. It encouraging the retrograde spell. So that causes endometriosis. So just now we see the pathogenesis, that is retrograde menstruation, colony metaplasia, direct implantation, lymphatic theory, immunological factor and other factors. Now we can see the pathophysiology. So what will happen when these endometrial cells or tissues that implant it fall into other some area? We already told just now about that. So each menstrual period, the seeded endometrial cells stimulated by ovarian hormones. So wherever this endometrial tissue or fall down, each menstrual period, due to these ovarian hormones, what will happen? These endometrial cells stimulated and the bleed into the surrounding tissue. That particular area bleeding will happen and causing inflammatory response. So that each month the same cycle happen. What will happen? That made up of become a palpable mass. It is known as chocolate cyst. It is like a chocolate cyst. When it rupture, what will happen? To spread the endometrial cells deeper into the pelvic. Repeated inflammation and healing create adhesion to fuse pelvic organs. So each month these repeated growth and rupture, so what will happen? It will cause the inflammation of the pelvis area, and that will become adhesion. We already told in previous class, that is the violin string like adhesion will occur, and that will cause the fuse the pelvic. So there may be violin string like adhesion and fuse the pelvic organs, or usually ovaries, bilateral, also pelvic, peritoneum, anterior and posterior cul-de-sac, and uterosacral, round and broad ligament. So because of all these problems, every month happens, progresses gradually and produce symptoms until woman is, so small remnants are there, and each month it is shed out and bleeding, small bleeding occur, and it will become larger and become a big cyst. And when the woman become 30 to 40 years only, usually the symptoms will appear. Next we can see the classification. It can be classified minimal, mild, moderate and severe. So what is minimal? So there is small spots of endometriosis seen at laparoscopy but no clinical symptoms. But in mild, scattered, fresh, superficial lesions can be seen but no scarring or retraction, no adnexal adhesion. So that will not be symptoms. In moderate condition, ovaries also involved with some scarring and retraction. They contain endometriomas not more than 2 cm in size. So minimal peritubal and peri-ovarian adhesions will be there, and endometriotic lesions in the anterior and posterior peritoneal pouch. So there may be small sizes endometrioma, that means the cyst formation can be seen. Then in severe cases, what will happen? The ovaries also involved, and with the size of endometriomas more than 2 cm. A dense peritubal and peri-ovarian adhesion. We already told the adhesion like violin stick adhesions are occur, severe rest. So that's why it restricts the mobility of the organs, and uterosacral ligaments are thickened and involvement of bowel and urinary tract also occur. This time there may be symptoms will be severe. So this is endometrium. You can see this is a chocolate cyst, which is ruptured chocolate system in the laparoscopy. So you can see this is the adhesion. It is all is connected like adhesions occur. So next we can see this clinical manifestation, and chronic pelvic pain that was just before the menstruation. So this is the main symptom. The person will be having the pain just before starting the menstruation, and which then improves during menstruation, but it will be improve at the end of the menstrual period. And dysmenorrhea. Dysmenorrhea is a painful menstruation. Then infertility. What is infertility? You know that abnormal menstruation such as menorrhagia, that is abnormal heavy bleeding at menstruation, polymenorrhagia, that is the menstrual cycle is shorter than 21 days, and or epimenorrhea, that is epimenorrhea means prolonged and profuse menstruation occurring at any time, that is epimenorrhea. And dyspareunia, this is the painful and the intercourse due to the stretching of the structures of the pouch of Douglas. Then patient will be having vomiting, nausea, fainting, dizziness, spells, vertigo. Then there will be severe abdominal pain, extreme pain in the legs and thighs if it is the ligaments of the thighs and legs are involved, and diarrhea and constipation if the bowels are involved, and blood in the urine if the urinary structures also involved, endometriosis in the urinary structure or bladder, and painful or difficult defecation if the bowels involved. There is a endometriosis, and chest pain or coughing, blood due to endometriosis if the lung has endometriosis, and headaches issues due to endometriosis in the brain. So these are the clinical manifestation. Next, we can see the diagnostic evaluation, health history and physical examination, serum marker. So I already explained you. So there will not be much symptoms in the early time. It will be usually appear at the age of 30 to 40 years. So then the patient may complains of pressure symptoms and pain, severe bleeding during the menstruation, and patient may have the lower abdominal pain. So if they came with these symptoms, we have to go for the ultrasonography. If find there is a cyst, then you have to check for the serum marker. The serum marker, that is CA125. If the blood level is marker is elevated more than 35 unit plus ml unit per ml, causes it is the main sign of endometriosis. Then ultrasonography, you can see like this. This is the CT scan result. You can see this here is a endometriomas. Okay. Then MRI also same like that, and laparoscopy and laparotomy can be done. That is laparoscopic examination. You can see a clear visualization of the endo. This is violin string. I already explained you violin stick like adhesions. This is violin stick and adhesions, and the biopsy is to confirm the this endometriosis. Next is the management. I already explained to patient, if the patient don't have any symptoms, that is asymptomatic and minimal endometriosis, just observe for the 6 to 8 months and investigate for the infertility. Sometimes the patient came with the infertility, so while doing the laparoscopy, we will find out that there is an endometriosis. And if the patient has symptomatic, we have to start the drug therapy, that is a pain medication, that is NSAIDs, that is ibuprofen, naproxen, sodium, then opioid analgesics, that is narcotic medication can be given to reduce the pain. Then hormonal therapy, the main drug of choice is danazol. It is given for the endometriosis. Main drug of choice is danazol. Then can be given the oral contraceptive pills, that is estrogen and progesterone combination, gonadotropin releasing hormone, agonists and antagonists can be provided, progestins can be given, and aromatase inhibitor, that is anastrozole and latrozole, that is the aromatase inhibitors. So these are the drug of choice, that is pain medications and hormonal therapy. Do not forget, this is danazol is the main drug of choice for the endometriosis. Next is a surgical management. Patient have severe symptoms and the size is more than 2 centimeter. Then the patient have the pain, severe pain. Then we have to go for the surgical management. That is aspiration of peritoneal fluid in the cul-de sac, remove the prostaglandin, and relieves the dysmenorrhea, pelvic pain, and destruction of endometriotic implants less than 3 cm by the diathermy cauterization. Can be cauterization, you already studied in the medical surgical medicine, and vaporization by the CO2, and does not cause adhesions and fibrosis. And cauterization of the cyst wall by performed in young women. And laparoscopic breaking of adhesions in pelvic relieves the dysmenorrhea and pelvic pain. So laparoscopy breaking of the this, because of this uterine and ovarian adhesion, severe pain is occurring. So that's why we can remove the adhesions by laparoscopic breaking. It restores patency of the fallopian tube and ovulation will occur normally. So sometimes it is a cause of the infertility. Then LUNA, that is laser uterosacral nerve ablation for midline pain in endometriosis, also very effective. Next we can see some of the surgical management. So this is a surgical treatment, laparoscopy. You can see the picture on this, and you can also refer the YouTube. You can see some laparoscopy surgery of the endometriosis. Next is a laparoscopy. Laparoscopy can do, and laparoscopic surgery of the endometrium should be done, and salpingo-oophorectomy can be done, and dissection and excision of the chocolate cyst. So chocolate cyst is open and excision, and sometimes if it is big one and complicated infected, we can do the dissection. And total abdominal hysterectomy plus DSO can be done if the person is completed her fertility. So if she had the family is over, then we can do the total abdominal hysterectomy plus BSO. The complication: endocrinopathy, rupture of the chocolate cyst, infection of the chocolate cyst, obstructive features such as intestinal obstruction because of big cyst, intestinal obstruction, urethral obstruction, malignancy. These are the main complications. Sometimes this cyst may go for the malignancy. Rarely it will go for the malignancy. That's all about the endometriosis. Endometriosis is the implantation of the functional endometrium other than the uterine cavity. So we till now discussed about this pathology, its types, its symptoms, management, and the complication. I think all of you are clearly understood. Thank you very much.